My name is Zoe Dang, and I am an MSW student at Grand Valley State University. Today, I'm going to be talking about treatment resistance in children and adolescents. So, what is treatment resistance? Treatment resistance is when a child, teen, or adult continues to experience clinically impairing symptoms despite an adequate trial of an evidence-based psychotherapy, and that can be with or without medication. Um, it could also be that the client has had a history of unfavorable treatment effects. So there are different types of treatment resistance, and there are three that I'm really going to focus on today. First are teens whose parents are making them go to treatment and they really don't want to participate. Second are younger kids who are unable to regulate themselves enough to engage in the treatment. And then lastly, we have children and teens who are involved in the juvenile justice system and are a part of treatment involuntarily. So, the prevalence of treatment resistance in teens and children. So first, factors that are associated with poor treatment responses include early adversity, current trauma, family conflict, parental depression, and getting bullied. Um, and these are mostly adverse childhood experiences, which you can see in the diagram here on the slide. Adverse childhood experiences include physical abuse, physical neglect, emotional abuse, emotional neglect, a household member who has suffered from mental health issues or who is addicted to drugs or alcohol. It could be sexual abuse, the loss of a parent due to death, divorce, or abandonment, or witnessing domestic violence, or someone, a parent, or someone else in the household who's incarcerated. So there are many different adverse childhood experiences that could contribute to poor motivation in treatment and resistance to treatment. In 2019, the CDC analyzed data from more than 144,000 adults in 25 states and found that 61% of them experienced at least one ACE in their childhood. And nearly 16% of adults experienced four or more ACEs. So this is a very prevalent factor when it comes to treatment resistance, and the fact that these early experiences can really stop any kind of motivation towards treatment, thinking that all of these experiences that they have gone through will cause treatment to fail in the first place. So there's no really reason to try. And then in one article that I found specifically on teenagers who are resistant to treatment for depression, it found that nearly 40% of adolescents remain depressed after their initial treatment. And over half of that population studied remain depressed despite switching up their medications or adding a different psychotherapy. And unfortunately, there is limited pediatric evidence to guide clinicians as to how to proceed therapeutically with treatment resistance. A lot of research now has to do with adolescents who are resistant towards depression or treatment for depression, or are resistant to treatment for substance abuse. So some risks of treatment resistance. First, juveniles receiving public mental health services are more likely to have encounters with the juvenile justice system. And unfortunately, these encounters with the juvenile justice system could also cause an exacerbation of their mental health condition. So this is a cycle that just continues with these adolescents, children. And then adolescents who do not respond to first line treatments for their depression have higher suicide rates, greater academic and social impairments, greater relationship problems with their family and their peers, and a greater likelihood of recurrence of depression in adulthood. So some common diagnoses with treatment resistance, like I mentioned earlier, most of the research, current research, is of depression and substance abuse. However, I did find research on eating disorders, borderline personality disorder, and anxiety. And the conditions of treatment resistance really can be found within any diagnoses. So, one thing that really makes treatment resistance a continuous factor in a child's life is family accommodation. So, family accommodation refers to changes that parents, siblings, and partners make to their own behavior to avoid or alleviate distress for the identified clients. So, if this is a child or a teen, it is most likely going to be their caregivers, their siblings, anyone else in the household that can accommodate their behavior towards their symptoms. So, this could involve modifying family routines, actively participating in the identified client's symptoms, or facilitating avoidance behaviors for those symptoms. And these changes really only lead to short-term reduction in stress for the child or adolescent. And it doesn't ever lead to long-term treatment or long-term positive effects. So studies have shown that accommodation is associated with greater symptom severity, functional impairment, and poor treatment outcomes. So if you refer to the diagram here on the slide, it shows the cycle of family accommodation. At the top, we have the initial distress or the behavior that is related to the disorder that is displayed by the client. And that then leads to family accommodation, which is those modifying behaviors of changing family routines or participating in the symptoms, avoiding the behaviors. And like I said before, that then leads to that short-term reduction in distress, which can be a very good feeling for the family members who are participating in this accommodation. But that accommodation leads to dependence on the parents for regulation. So that client will never learn or really want to learn any coping skills that will actually reduce those behaviors because they are just depending on the accommodation of their family members for that regulation. So that then leads to the maintenance of symptoms being obsolete. It leads to the exacerbation of symptoms. And then the cycle just continues. The exacerbation of symptoms is the behavior, which then leads to more family accommodation. So research has shown that family involvement is ideal when working with clients who are resistant to treatment. So when it comes to treatments for children and adolescents who are struggling to motivate or participate in treatment, really has to do with engaging the parents. So with younger children, you can teach behavior therapy in parent groups or in family sessions, and this mostly has to do with behavior modification principles. You can also teach the parents effective behavior management skills and improving the parent-child relationship through different practices such as providing specific praise, creating house rules, using charts or other incentive systems, and just making sure that the child knows what to expect when they're in the home. A couple of examples of really great treatments that focus on these aspects for younger children are the Incredible Years Parenting Program and parent-child interaction therapy. Moving on to teens, and specifically teens involved in the juvenile justice system. It has been found that incorporating behavior therapy, CBT, and family therapy has been very helpful in involving teens through the justice system in their treatment. So all three of these modalities would be used in a combination of family sessions, parent-only sessions, and child-only sessions. And it would be a treatment team approach So it would provide 24/7 support for families, having an on-call clinician in case of crisis, and then also involving multiple stakeholders in the child's environment. So if they're involved in the juvenile justice system, this may include probation officers, it can include teachers, so not just caregivers or household members. One specific model that is very helpful with teaching parents these skills is community reinforcement and family training, or so this is a model, a parent-based model that focuses on meeting with parents and providing help for those parents who want it, regardless of the participation of their child. Um, and it is independent from the child's treatment. So it can help reduce barriers to the child's involvement, decrease parent stress, improve the parent-child relationship, and help parents to more effectively address problem behaviors. So this model allows for parent psychoeducation and support. And the goal of that is to help, is that these educational measures will help the child or the teen become regulated and therefore more motivated to start treatment. So these components would be taught in this order, starting with functional analysis, where the family is taught to identify the child's triggers. Then they would be taught positive reinforcement to reinforce the child's positive and pro-social behaviors. Next, the family would be taught competing reinforcing activities, so how to interfere with the child's negative coping skills, which could include substance abuse or self-harm. And then teaching them planned ignoring and how, when done appropriately, ignoring problem behaviors can actually lead to the extinction of those behaviors. Next, we have natural consequences. So teaching the family to avoid interfering with any natural negative consequences of the child's actions. And this could include, for example, getting in trouble with the law because of substance abuse and things of that nature. Next, we have communication skills training. And this assists the family in learning positive communication while also seizing their negative communication with their child. And then it also helps families learn how to deliver appropriate consequences for their child. And then next we have treatment entry training. And this is when the therapist or clinician trains the family to recognize appropriate times to suggest treatment for their child and ways to suggest it that are more likely to succeed. And that it is also the responsibility of the clinician to have any treatment options available for the child to start immediately when that decision is made, so that there is no time for the child to change their mind. And then lastly, we have life enrichment. So back to the parents, this is helping, or the caregivers or whoever is in the household, helping them to decrease their focus on their child or client once the treatment has started, and to focus back on their own lives and their own activities and what fulfills them. So some important factors when treating children who are resistant to treatment is first to meet them where they are and not where their parents are. So children will come to therapy because their parents told them to and not because they want to themselves. And this is why it's so important to ask the teen or the child what it is they're experiencing and feeling and what they want to get out of therapy, and whether it's the same or different from what their parents want. And this is kind of the same thing as this feeling versus appearing. Basically, paying attention to what the child says they are feeling, because it's very easy for a therapist or a caregiver to say how the child appears, like they appear angry or distracted. But in reality, they may be depressed or anxious. And what you're seeing is just how they are coping on the outside with those emotions. And then the therapeutic relationship is so important. Resistance will come up a lot more if the client doesn't relate to you. So this is an important factor when working with individuals with a different sexual identity, sexual orientation, ethnicity, or race than your own. A lot of research has mentioned that being a part of those minority groups actually increases the likelihood of treatment resistance, However, this has more to do with not having enough people of color or people of the LGBTQ plus community as therapists in the field. So next, I am going to share some interviews I did with some LMSWs that have experience with treating children and adolescents who have been resistant to treatment. First, we have Vanessa Hurwitz. All right. And next we have an interview with LMSW Jen Cottingham, who has experience working with younger children under the age of 6. All right. Um, and now to finalize this presentation, I'm going to go over some ethical considerations. So, when treating children and teens who are resistant to treatment, um, it's important to consider that treatment resistance may sometimes be due to a comorbid diagnosis. So, for example, if a child is diagnosed with both ADHD and depression, focusing on those ADHD symptoms could then improve the child's social and scholastic function, which could then improve their self esteem and mood. So, just knowing in a comorbid situation which symptoms should be treated first to effectively treat that child. And then interventions for mental health should be addressed within the juvenile justice system. As I mentioned earlier, teens and with mental health diagnoses are more likely to have run-ins with the juvenile justice system, which can then further exacerbate their symptoms. And this is a cycle that needs to be broken from inside the justice system. And then lastly, I wanted to talk about the difference between what major depressive disorder looks like in adults versus children and teenagers. With adults, as you can see in this diagram on the slide, they experience anhedonia as well as depressed mood. However, with children and adolescents, they could be experiencing or showing a depressed mood or an irritable mood. And this can sometimes cause misdiagnoses in many children, and such as oppositional defiant disorder, bipolar disorder, and disruptive mood dysregulation disorder. And when they are misdiagnosed, these children also end up receiving medications that are not helpful or necessary for their condition, and then they are also deprived of medications that would actually help their depressive symptoms. That is all I have on the treatment of children and adolescents who are resistant to treatment. Thank you so much for listening and have a wonderful day.